Hello, everyone, and welcome to today's webinar titled IHME Covid-19 Projections for the U.S. Strategies to Reduce the Spread. This webinar is part of the Coronavirus Virtual Event Series, and I'm Susie Valdez of Labroots, and I'll be your moderator for today's event. Today's educational web seminar is presented by Labroots. So let's get started. Before we begin, I want to remind everyone that this event is interactive, and we encourage you to participate by submitting as many questions as you'd like during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have any trouble seeing or hearing this presentation, just click on that Ask a Question box located on the far left of your screen. As a reminder, this presentation is educational and offers free continuing education credits. Click on the Continuing Education Credits tab located on the top right-hand corner of your presentation window and follow the process to obtain those credits. Without further ado, I now present today's speaker, Dr. Ali Mokdad, Chief Strategy Officer with Population Health at the University of Washington. For a complete biography of our speakers, please visit the Biography tab at the top of your screen. Dr. Mokdad, welcome. You may now begin your presentation, sir.
Thank you for the introduction. Good morning, everybody. It's a pleasure to be with you this morning. I want to talk about IHME Covid-19 models and strategies to reduce the spread of Covid-19. My presentation will introduce the model, drivers of the model, projections for the United States. I'll talk about our limitations and how can state use these estimates to control the pandemic. Before I do so, let me tell you briefly about the Institute for Health Metric and Evaluation. We are based at the University of Washington. We've been here about 11 years, and we monitor, address three questions. What is the world's major health problems? What is the society doing to address these problems? And the third one, which is the most important, is how can we, given the resources that we have at hand, how can we maximize our output? For Covid-19, we have a large team working on Covid-19 projections led by our director, Christopher Murray, and several faculty here, as well as post-bachelor fellows, data analysts, and of course, engineers and enterprise data managers. And visualization, as you will see, all our data is available with the visualization on our webpage. The history of our model, it's originally started by a request from UW Medicine here, our hospitals. We have one large hospital here, which is a referral hospital for the whole region in reality. And they came to us and asked if we can provide projections about how many beds they will need, how many ICUs, how many ventilators, so they can prepare for the surge. Started doing this for our hospital and our county and adjacent county where our catchment area for the hospitals are. And then we got requests and we started releasing this for every state in the United States. And now we do it for every country in the world. And for many countries, we do it at the subnational as well. What we are trying to answer is how many people are dying, will die from Covid-19. We'll project 4 months into the future. And we decided at IHME to do projections based on deaths, as you will see in my talk, because early on we didn't have enough testing and we didn't know how many people in a community are infected. So we felt mortality is a better indicator of what's happening. If we follow mortality and we do projections of mortality, we can back calculate what is needed. For example, how many people are dying, and then we can look at how many people were admitted. So that ratio for each death, how many admissions we have, within this admission, what's the length of stay, how many people are on an ICU, how many people are on a ventilator, of course, by age, by sex, for all of those. And we provide scenarios right now for our estimates. So what if 95% of the population wear a mask, which is what we see in Singapore and other countries in Asia? And what if we keep relaxing our social distancing mandate? What will happen? And if we follow the reference scenario that I will explain shortly. And as I mentioned, we take the age-specific deaths using age pattern of mortality reported to us. And I'll give you the sources of the data, median time of admission to death, and then we back calculate how many people were on ICU, how many invasive ventilators, using the length of stay as well, to know how much, not only beds you need, but bed days as well. Our data sources are from Johns Hopkins. We use Johns Hopkins. They have a wonderful web and a lot of great data that we can easily download. We look at COVID tracking projections, where they have our world in data, where they have a lot of testing data as well. Social distancing data is obtained by a number of different sources, but basically we look at countries and state, when did they impose a mandate, what type of mandate. Mobility, we get it from Facebook data for good, Google Safe Graph and Descartes. And internationally, we get it from Facebook and Google. Mask use in the United States, we get it from Premise. Everywhere else in the world, it's from Facebook. They do about 5 million surveys a week, and they add questions. We work with them, both Premise and Facebook, and we get that data for them to use it in our modeling. Hospitalization rates, we have several locations. Like in my state, for example, we don't know how many people were admitted in the hospital. We know in our hospitals, but not in the state hospitals. But that data, when available, we use it in our models. Some of the data we get is problematic. This is an example from the UK, and you will see later on in the United States, it's unfortunately the same. The several problems are there. One of it is, unfortunately, on Saturday and Sunday and Monday, you see less reporting, and you see it clearly here. There's a gap, and then you see a number increasing, then it comes down, then goes really down on the weekend and Monday. Then it is reported on Tuesday, and that's not a fault for any health department. You know, on the weekend, they're collecting the data, compiling it, and releasing it on whenever it's available, either Monday or Tuesday. So you see the zigzag in data. It comes in one day more than the other day. And we have here a way to go and reassign those deaths to a previous day based on what the trend that we have seen in the past week. It's very important for us to do so. Otherwise, our models will, if we do it, let's say, if we run it on Monday, it's assuming that the cases and the deaths is coming down and cases are coming down and so on. So it will impact our projections. All what I'm presenting to you is available on our web. If you Google IHME COVID-19, you'll have the model, and for every country in the world, you will have all the variables that we use in our models. You have notes for updates on our changes in methodology. You have all our publications. You could download the estimates yourself. You could download the some of the visualizations. There is a way to do so, and we answer some frequently asked questions. Let me briefly talk to you about the model that we are doing. We are in our third version of the model, and that's a very important finding that we have realized in our work and for COVID-19. Our first model, first release was March 26th for the United States. From March 26th to May 3rd, we were using a curve fit model. And that model did extremely well, predicting the peak of the pandemic in the United States. But after that, the decline, it didn't do at all very good. And the reason for it, early on, we didn't have data about what will happen once you reach a peak. All the data we had before was coming from China, South Korea, Italy, and Spain. They were ahead of us when it came to the pandemic spread. In these countries, the model was symmetric, so it was curve symmetric. It went up and it came down. In the United States, it came down slowly and dragged for a long time. That assumption didn't fit, so we switched to a curve fit SER model, and I'll show you what we mean by SER: susceptible, exposed, infected, and recovered. And that hybrid model did very well until June 10. Then when we came down, and then we started going up, we switched to what we call random knot combination spline. The best way to describe it is like when we were kids, we used to draw a picture by connecting 1, 2 to 3, 4, and 5. That model takes the short distance between 2 points and curve it and make it a curve. And in our random knot combination spline and SEIR hybrid model right now, we use for our projections mask use, cell phone mobility data, pneumonia seasonality, because we find it very strongly associated with COVID-19. Testing per capita, early on testing was very significant because the more you test, the more you find cases and you're likely to remove them from exposing others by isolating them. Population density, big cities, they live together, public transportation and elevators and so on. Particulate matter 2.5, smoking is a big variable, altitude, and pneumonia death rate because of the pneumonia. And the way we do it is we take the past 8 days in all our models, and we look at the relationship between these variables and our outcome, deaths in this case, in the past 8 days. And we build that relationship. And then we project all the variables into the future, all the indicators, and then we can project mortality into the future. And we do it the last 8 days because things are changing, and the relationship, once things are changing, the relationship between these variables do change. And we take the last 8 days to adjust for this issue of declining reporting over the weekend to make sure we cover a period of reporting for the whole week. For those of you who do modeling and projections for infectious diseases, it's susceptible, how many people and what the percentage of the population that's susceptible, how many of them are exposed. And we have 2I, infected and infectious. So some people are infected, but they're not infectious. And they are infectious for a certain period of time and they turn out not to be. And removed is either recovery or unfortunately death. And that's what we are predicting. We are predicting a beta that people in our business talk about R naught. We are interested in RT, which is effective R, because R is changing throughout the time. R naught is at the beginning of a epidemic or a pandemic from infectious disease modeling. The problem with SEIR models, they tend to overestimate the number if you don't account for what the population is doing. So if you take a model, for example, susceptible and exposed and infected, and you don't take into account what the country is doing or what people are doing to change their behavior, that model will assume the same will stay constant and will project an overestimate of the number of deaths. So that's what happened with the imperial model. In our modeling early on, we decided that it's not gonna, no country or no location in the world will allow a pandemic to keep rolling without taking some measures. And the measures early on were mandates in our model. So we looked at what China did. And when China started imposing mandates, closure of educational, shutting down the airport, at the end, like 6 mandates that every country used, we've seen the impact of these mandates. And we put a prior in our model. So we told our model basically when a state will put such a mandate, we expect a certain percentage decline in infection. And that's what happened. And we used that. So countries do provide a response, and it's kind of accounted in our model. With what I'm saying right now, with all of our attempts to make sure that we don't overestimate the numbers. For many locations, unfortunately, especially for sub-Saharan Africa, our model and many of other models don't perform as well as they perform in Europe, for example, or the United States, for several reasons that I will briefly discuss in our limitation. But to give you an idea what we do here in our data and how we use it for projection. If you look at the top left, cumulative deaths, we're running cumulative deaths by daily deaths. So if you look at daily deaths at the bottom, this is what we get on a daily for Florida. And you could see the zigzag in mortality. It goes up, comes down on a daily basis. And you could also tell when the weekends happen. So we're plotting because we know cumulative deaths is not as sensitive up and down zigzag like a daily death. We plot daily deaths by cumulative deaths, and we can understand the relationship between daily deaths and cumulative deaths. We do the same for right now for cases. So the one in the middle, cumulative deaths versus cases. So on the axis, we have cases, daily cases. At the bottom graph, you see daily cases. They go up and down zigzag, and they've been increasing in Florida at that time. Now they're coming down if you look at the end of the graph here. Again, we plot daily cases by cumulative deaths. Admissions to the hospital. In Florida, we have admissions. You could see the bottom hospital admission is going up and down, zigzag reporting. And whereas it's a better relationship when you look at hospital admissions with cumulative deaths. And then if you come back to the daily deaths graph, the red line takes all this information. So daily cases, cumulative deaths, admissions to the hospitals, and plot that curve, the red one that goes into it and shows the trend. So it went up early April in Florida, came down, and now it came up, and now it started to come down. But that's how we do it. And using the past 8 days, we get the relationship between the covariate. Let me show you the covariate. So in social distancing measures, mandates, there are 6 of them. Educational facility closed, non-essential business, people ordered to stay at home, severe travel restriction, partial non-essential business ordered to close. Some state did that in the United States and restricted the group gathering, different size, but there was a group gathering restriction. But there's 6 mandates that every country used, and we use these 6 mandates in our estimates. So let me show you what happened globally. All countries in the world, all countries, all states impose certain mandate, not 6, I'm plotting here 6, the highest is 6 mandates, but you could see all countries in the world by mid-March started imposing mandates. So all the mandates came at the same time, and that has given many countries a false sense of security. And I will explain it for the case of Florida, for example, when you will see later in one of my examples. So what happened here is when a state put a mandate, say New York State, at the time that New York State put a mandate, there was a lot of infection going on because New York and Washington State, my state, were ahead of everybody in terms of the cases, seeding of the number of cases. For example, a state like Florida, when they imposed a mandate, they didn't have as many cases at that time. So for a long time, they felt safe in a way, and they can lift this mandates because the mandates showed like basically there is not that much effect when they were lifted because of the seeding in Florida. There were not much cases early on. For a month or so after lifting the mandate, they didn't have cases. Then they started going up because this is an infectious disease. We're all susceptible. It's highly infectious. It will go to exponential growth once given. So that issue of early mandate for certain places, unfortunately, led to a false sense of security in the future. And sometimes states that relaxed and didn't pay attention, people didn't see COVID-19 in their community, and they felt safe and they're immune to it. Then, unfortunately, COVID-19 came and hit them. To show another point, these are 2 graphs, one in South Africa, one in an India location. You could see it. Mandates came down about the same time. Mobility went down extremely. In our webpage, we have the timing of the mandate, a nice visualization, hard to see, but it's available on our web. But you could see for every state, when did they impose the mandate and how many mandates they have. Only one state had 6 mandates, stop to travel, but all other states at one point of time had 5 mandates maximum, and the duration varied by state, of course. So mobility as measured by mobile phone, and I have to be very careful as an epidemiologist. In the United States, most people have a mobile phone and a smartphone. But in many international countries, that's not true. So we tend to overestimate a decline in mobility because the rich and affluent people are answering in other countries, say where I come from in Lebanon. But in the United States, that's not a huge problem. But if you look at the map in the United States right now, Many states are almost back to normal mobility, similar mobility that was in January. Unfortunately, we don't have mobility before January from our sources. So our baseline is January. We wish, of course, to have a baseline to be the same months, August compared to previous August, because we know summer people do travel more. What's important in this graph is you could see that states that are impacted the most tend to have less mobility. And we see that response. So we see when a state, New York City, has a problem, people are more likely to wear a mask, people are more likely to stay at home. Then when the cases start coming down, they relax and they let down their guard and they start, moving around much faster. So if you look at mobility here in the United States, I'm giving you some states. You could see it came down sharply after the mandate. If you look at Florida here, the light blue line, Florida put one mandate compared to New York and my state, Washington. And with one mandate, Florida mobility went down to like minus 56% by closing educational facility. Because in many places, educational facilities, especially schools, are associated with other activity besides kids coming to school. There are parents meeting, there are sports activities. So you see it coming down. The other important point here, you could see mobility in Florida and other states started coming up even before lifting the mandates. So in Florida, for example, I'm not picking on Florida, but I have the data for it and we have hospitalization from Florida. For Florida, for example, you could see the first week of April, mobility started going up even before lifting the mandate. And the reason here is when you start talking about lifting the mandate and everything is going in the right direction, people start moving around. They, in their mind, it's getting better. Now the governor or the state health officials are talking about opening the country or the state. It means we're in a good shape. So mobility started going up even before a mandate was lifted. So for us early on, when we didn't have mobility data and we were counting on a mandate, we assumed that mobility was very low because we have a mandate still in place. When we got the mobility data, our estimates, of course, went up because we realized mobility started before the mandates were lifted. We're learning a lot from the data and what's happening here as this pandemic is unfolding, unfortunately, in the United States. These are the percentage of people, prevalence of people who, when they are outside their houses, they report wearing a mask. And you could see in many places in the States, it's about 50% right now. It went down the last week, unfortunately. You could see that many states are less than 30% people wearing masks. Again, you could see more mask wearing in Florida, Texas, and California because of the recent increase. People react when they hear in the news their state is not doing well. They wear a mask, they stay at home. Then when the numbers come down, unfortunately, the reverse is true. Here is some state, you could see mask wearing was coming up for all states, even national, it's coming down the past 2 weeks. Unfortunately, it's coming down. We're getting into fall and winter where seasonality will increase COVID-19 and we need to be much careful right now rather than relaxing. This is daily testing of COVID-19 in the United States by state. So some states do more testing. New York, for example, stands out at doing more testing, followed, of course, by several states that have been heavily impacted by COVID-19. Early on in our model, testing was strongly associated with a reduction in transmission. It's not as much anymore right now. We see almost no effect of testing, which is very controversial. But because there are delays in the results, that's one. Two, because right now the number of cases that we are catching on a regular basis are very hard to do contact tracing and isolation and testing of the contacts. So for example, if you take Florida, one point in time they had 15,000 cases a day. It's very hard for a health department to trace 15,000 and still they had another 10,000 or 12,000 the day before and so on. This is trend in daily testing per 100,000 compared the US to other countries. It's very important to remind ourselves that we're doing a good job in testing. It slowed down at the past couple of months, but now it's picking up. But we have really increased our capacity for testing in the United States, and we are doing a lot of tests, so that has improved. This is percent of people who are, we estimate from our models that have been infected. So it's very important. People talk about this herd immunity, that we're going to get a herd immunity if a lot of us are infected. We are still far away from a herd immunity. The highest we see right now is in New Jersey, New York, and Louisiana because of the infections that happen in these states, but most states in the United States are still less than 10% in terms of infection. So lots of us are still susceptible for this virus, and we have to be very careful. Trends of percent who are infected, you could see it is increasing. California now is going up, Florida is going up. This is our ability to detect how many people are, the change in infection rate, and that we are able to detect. So basically, out of every infection that's out there, how many we are able to detect in the United States? It's improving, it's increasing, not everywhere. New York has been flat because even with the increase of their testing, a large population, but in other places, out of every 100 cases that have COVID-19, for example, about 37% are being detected in California, for example. So we have a lot of cases out there because they're asymptomatic that we are not able to detect. So many people are infectious and walking around. That's why it's very important for all of us to assume we are infected and wear our mask. This is a graph of showing you the pneumonia deaths by week in the United States for the past 5 years, and this is the last year. You could see it goes up. It doesn't come down to zero. It's not like flu. Flu almost, you don't see any flu past May, very rarely. But pneumonia sticks around, but it goes up again in fall and winter in the United States. We see a strong association between COVID-19 mortality and pneumonia deaths. We've seen it in the Northern Hemisphere. If you take data from Australia, South Africa, Argentina, that's the beauty of IHME, because we do this at the global level. We have data from everywhere. For example, Argentina, with all their strict mandates, cases kept going up in the winter. Now it's coming down, and could not be explained by mask wearing and by mobility. So it was a strong association with pneumonia as well. So if you look in the United States, we're coming into the difference between August and February is we will see right now a rapid increase in the chance of getting pneumonia, which means the rapid increase in the spread of COVID-19, unfortunately, when we come into fall and winter. And that's why we are concerned that our numbers projection will increase. We do a good job predicting those seropositive surveys out there. So we compare ourselves to data, except for Spain here. Most of the surveys that said this is what percentage of my population has been infected. In our models, we're very close to that. This is available on our web, but it's very important for me that we monitor our programs. There is even a publication by outsiders who compared our models to our other people who do the same. All this data is available. We do very well in our models. We are the best model out there in terms of predicting the future. That data is available on our web and the reference of the publication that said that. And we do monitor ourselves as well. So in our current scenarios right now, we have, let's leave everything, let's call it, for the sake of this presentation, herd immunity. So we ease the mandate, we do nothing. And then universal mask use, which is scale up mask use to 95%, what will happen? And the current projection, which is very important to remind everybody in our modeling, is we assume in our current projections right now, based on mobility and mask wearing, that if cases reach 8 deaths per day per million, there is a reimposing for mandates for 6 weeks. So in a state where we see this is going to happen, and we assume the mandate happened, we're going to take effect. So we're going to underestimate mortality if the state doesn't put that mandate in place. That happened before because we assumed that states will put mandates within 7 days of each release. States didn't do it. We also assumed at one point of time in our estimate that states will not open until they reach a certain level of infections, and we provided a map when you can move to open and relaxing your mandates, and many states didn't do that, so we underestimated the impact. So in the United States, briefly, all this data is available on our web, and this is the estimate from last week. We usually update our estimates on a weekly basis, so this data is last week. It's what's available on our web. We are projecting between now and January 1st, 415,000 deaths. If people wear a mask, this goes down to 200. Almost 230,000. A lot of lives could be saved by 95% of us wearing a mask. If we go into a herd immunity, we're talking about 600,000 deaths, which is a huge number. And we're about 200,000 deaths right now. So in our current scenario, we're doubling mortality between now and January 1st. If our estimates hold true, and that's true on a weekly basis right now, COVID-19 is the second leading cause of death in the US. But if estimates hold true, by the end of the year, we will have out 415,000 deaths. That would be the second after ischemic heart disease in the US, before lung cancer. So it's a very deadly disease. In terms of daily infections, we're expecting that December will be a bad month. We'll reach about 3,000 infections, and then goes down to 2,800 towards the end of the month because of the reimposing of the mandate. This is a level that we have seen in April, mid-April, but it will be a little bit higher in December if we do not do our part, wearing a mask, staying away from each other, and the mandate when we reach it. This is daily infections, and estimate how many infections we will have on a daily basis. Right now, we reach at one point of time about 350. We will see it the same way in November, December. November is when we see the highest case. December when we see the highest mortality. It goes about 400, almost 450,000 on a daily basis, unfortunately, if that's our reference scenario with all the mandates. And what we're assuming here is states will impose these mandates. They will reach the 8 deaths per day per million in September, October, November, and December. And very few states will not reach that point and will not have to reimpose mandates, unfortunately. It's very hard for me to talk about mandates. I have family members who are struggling. I can work from home. Many of my friends and relatives cannot work from home. So it's very hard to say it. But that's a reality, unfortunately, because we are afraid that if it reaches a high level of infections, we will overwhelm your hospitals, and you need to protect your hospital and save some bed capacity for other use, not COVID-19. What are the limitations, briefly? And I'd like to end shortly and then open it for questions. We have under-testing and under-reporting in many countries. It does not capture our estimates, the extension of bed capacity, the surge. Hospitals could add bed, could add ICU, are buying ventilators. So we may underestimate what a state has unless the state calls us and provide us this data. And it happens in the US. We get a lot of the update from the state. We don't know the testing, who has been tested. So in many countries in the world, in the US, we don't know what the percentage of people who are symptomatic or asymptomatic that are being tested. And for us, knowing how many of the asymptomatic are being tested and caught is very important because it tells us a little about the infection in the community. Many hospitals, many states do not tell us how many hospitalizations they have. And we don't have many seropositive surveys to know how many people have been infected in a state. So we can use that information in our projection, knowing, for example, in my state, that 15% of the people have been infected with COVID-19 would be very helpful for us in order to do these projections. There are a couple of things that I want to mention that we see globally, and they're very hard for us to explain, and we follow them in close detail. So I am on the phone talking to the Minister of Health in Pakistan and colleagues in Pakistan. If you take Pakistan, for example, it peaked very poor country in places, a very dense population. If you take Karachi, for example, or Lahore, it peaked and it came down. We can't explain what happened. I mean, they're not testing as much. People are not wearing masks as much. People are moving around. So we are speculating here that there are a couple of things going on, and that could be true in many communities in other parts of the world. The first one is there has been previous infection of coronavirus, and T cells remember the coronavirus and they're ready to deal with COVID-19, so you don't see cases. Cases do not, they're asymptomatic, they don't come to you because of previous exposure to COVID-19. That's one. The second one, we feel that the circle, the bubble of people I interact with, at one point of time, the key nodes in this bubble, the merchant, the store owner who people interact with, is either infected and removed this, or now he or she are immune, and you reach a saturation of infection at a lower rate of infection, what people are calling herd immunity at a lower level within that bubble, because you took out the key spreaders in this community. Something we are monitoring. There is underreporting, of course, of cases and deaths in Pakistan, but we know from hospitals, we know from our colleagues, we have a large network of collaborators in Pakistan, that the numbers, although they are underestimated, but then reflecting the reality. So that decline is true. The peak may have been higher and the decline is now coming from a higher point, but that decline is very true in many parts of the world. Something to keep an eye on, we're monitoring it. What we expect also, in addition to monitoring mortality, that there is a strong impact of COVID-19 on other key factors: domestic violence, women's health, reproductive health, contraceptive, childhood immunization. People are afraid to go to doctors and hospitals. So many chronic conditions, diabetes, cancer, there is a delay of seeking care that will impact health on the long run. In many countries in the world, malnutrition, because people are not making money and their income is made on that day. So there is malnutrition, long-term impact of health as well. So something to keep an eye on, and we are concerned about that at IHME, and we will see the long-term effect of COVID-19 and the lockdown as well. Education, of course, and employment, which is a vicious cycle. Social determinant of health will go down. And of course, large impact on gender equality, and what type and other types of inequalities, unfortunately. So women will suffer the most. We're afraid, for example, in international countries, that many girls who didn't go to schools this year because of COVID-19 will never go back to school, unfortunately. MMWR reported, for example, here in the United States, that there was a decline in immunization. Parents are afraid to take their kids to see a physician for immunization, even in the United States. So that's very, concerning. Of course, there is excess mortality in every country in the world. We see it. So here are two examples that I'm giving you. One is, if you look at what's happening in Spain, for example, and Ecuador, Spain has a better vital registration system. So there is excess mortality. In the United States, we know there is excess mortality. New York Times said 200,000 deaths a while back, before we were much lower than 200,000. France published on excess mortality. In countries like Ecuador, where poor vital registration available right now, we see even much more deaths being reported, that we can explain what's happening in this country. Except COVID-19, nothing has changed. There is no war going on. There is no civil unrest, no disaster, natural disaster. We noticed in our data that states that have mask mandate, that more people are more likely to wear a mask. And if there is a penalty with that mask mandate, and even in many countries, that's even more likely to wear a mask. If you look at globally, we in the United States do not like to compare ourselves to other countries, but in many countries in the world, there is a penalty. In Lebanon, where I come from, there is a penalty if you don't wear a mask. You get ticketed. In Israel, there is a penalty, and the penalty has just recently increased, for example. We don't have a monthly random sample of seroprevalence survey. We don't have what hospitals are doing, who's been admitted. We want to make sure we can improve the surge capacity of hospitals. We are hoping that if cases start rising in November, and they will, according to our models, that states, countries will have make the right decisions by closing some of the places that are likely to increase infections, such as bar, indoor dining, and gathering as well. And then we would like to, if we can, do other modeling for people, like we can work with some states and show them, like, if you close certain things, what will happen. So instead of going into a total shutdown, you can do partial shutdown. And one of the things that we have been asked to do is what we call pulse. Is can we model when we come into winter, if we shut down for 2 weeks and open for 4 weeks. So businesses, it's easier for them to know ahead of time when they're going to shut down and be ready for it. So states can use this information right now for preparing for capacity. They know when they're going to reach a high level of infections, because we project infection not detected, but what we think are the infections in that state. And state could use this data for better planning. Businesses could use this data for better planning. This is all what I have to say. Thank you very much, and I'm happy to take questions.
Thank you so much, Dr. Mokdad, for that informative presentation. We will now start the live Q&A portion of our webinar. If you have any questions you want to ask, please do so now, just by clicking that Ask a Question box located on the far left of your screen. So let's get started. Dr. Mokdad, there are quite a few questions already coming in from our audience. Our first one comes from South Africa. The audience member says, I wondered if the recent theory that coronavirus morbidity is higher in ethnic minorities has factored in the surprisingly low death rates in places like, for example, Southern Africa, where the Black population is the majority instead of the minority. Do you have any theories about what may be influencing unexpectedly low death rates in Southern Africa?
A very good question. So in many countries in Africa, for example, when you see less mortality, it's you have to look at it from a population standpoint. That's a younger population. So if you take Egypt, for example, 40% or even a little bit more than 40% and less than 40 years old, the population is very young. And we know mortality is much lower in younger age group. So that's why you see less deaths in certain parts of Africa.
Thank you so much. Regarding the COVID-19, when you say it is the second leading cause of death in U.S., how are these numbers calculated? That's the first part of the question. And does this include individuals who die of any cause who are COVID-19 positive, individuals in which COVID-19 contributed to death from other comorbidities, or death strictly second to the virus, maybe? Please delineate.
Oh, very good question. CDC, National Center for Health Statistics, has a protocol for mortality. So for each death, there is a cause of death, primary cause of death, and underlying causes of death. Right now, this mortality, the 196 or 97 deaths that you see in the United States, the primary cause of death is COVID-19. On the death certificate, somebody may have also, like they have heart attack or they have diabetes, but they died because they had COVID-19 and debated it. So we follow the previous. This exactly what used to happen with flu, for example, and previous year when somebody dies with flu and then they had a heart problem as well. Nothing has changed here. So these are primary causes of death according to ICD-10 codes, according to all the protocols that CDC has. The question that you didn't ask, but that's the most important one, is, are we underestimating COVID-19 mortality? Because as you mentioned, it's a great question. Somebody could have died from a heart attack, but because he or she had a COVID-19 or afraid of COVID-19, didn't go for a medical care. And how much of this death has to be redistributed and assigned to COVID-19? This is something that has to be done later, looked at our mortality in September in the United States by state, by age, by cause of death, and compare it to 2019, and any change, except like for fire or accidents or any natural disaster. That could be, part of it could be attributable to COVID-19. But right now, it's simply primary cause of death, underlying cause of death, similar to what we do before. Good question.
Thank you so much. And I want to thank our audience for these great questions coming in. We love a great live audience. Have you modeled how a vaccine will affect these numbers based on vaccine efficacy as well, like 70% versus 90%? And also, when such a vaccine is approved, for example, October versus December?
Again, a very good question. Yes, we have been asked to do so. And right now, internally, we have extended our projections of COVID-19 mortality all the way to January 2022, so 1 year from now, 1 year and more from now. And yes, we have now doing some micro simulation when a vaccine will be introduced. Remember, most of the vaccine are 2 doses right now. When 2 doses are given, what will happen? We're taking different scenario of the efficacy of the vaccine. IHME, my group, we have done this work before for other vaccines. We've done such work for the introduction of rotavirus vaccine and others. So yes, we've been asked to do it. Yes, we are starting to do that. Very good question.
Thank you so much. Dr. Mokdad, would you mind putting up the slide that had the 6 mandates back up on the screen? We've got a couple of questions focusing on that slide and had that request. And one of the questions that our audience member asked was, which of these mandates do you believe is the most pertinent for us? And then, of course, there was a couple of requests. Could you just put it back up? Because they wanted to have that.
Very good question. So the best mandate we have seen in the United States, by the way, in the United States that has done the amount of declining of mobility is closure of educational facilities. When schools closed and all states did educational facility closure first, almost, in all states, about 40 to 50% decline in mobility. And again, this is because schools are associated with other activity besides kids going to school. The reverse is true. So now we have the mandate in our model and lifting the mandate, because right now, if you look at it from the different, so in lifting a mandate for school doesn't mean mobility that declined when it was imposed will be the same. The reverse is not true, because even if kids go to school right now, families are not going to meet and have a football game or a baseball game. So we still have a mandate. And also in our modeling, we assume that before any mandates, mobility went down by 10-15% depending on the state. So we're assuming unless all mandates are lifted, these people who stayed at home early on because they can't do, or because they have other conditions that they are afraid to get out, they're not going to come out of their houses until all mandates are lifted again. So there is a combination of the mobility, which is better indicator in our models right now, and the mandate itself has somehow an effect on people behavior. Very good question.
Thank you so much. Now, this next question is about the mask mandate. In regards to the universal mask mandate, what are your thoughts on masks that do not filter particles as the N95 mask does? Are those masks still effective?
No, very good question. So we have a publication on this, and we have a lot of details on masks on our web. We have done a meta-analysis for all studies that have been published on the masks. And because COVID-19 is so new, we didn't have many studies at that time. We had only 2 studies about mask effect on COVID-19, but we had on other respiratory diseases. And we looked at different types of masks. So, of course, the impact of masks in reduction of transmission varied from 40 to 60%. 60% is the N95 type. 40% was the lowest we have seen, which is a cloth mask made at home, for example. And in that 40%, to tell you how conservative we are in this estimate, and we may be well underestimating the effect of masks, we took the confidence interval of that 40%, the lowest study, the least effective mask, 40%, and we took the lowest confidence interval of that 40%, which was 34%. So we're assuming in our models The effect of mask, if you wear a mask, you reduce transmission by 34%, where in reality, we know it could be much higher. But any mask will work if worn properly, and a closed mask. And then, of course, there are different types of masks. Some of them are way better than the others. But a cloth mask made at home, when you wear it properly, reduce transmission by 34%.
Thank you so much. And we have time for one more question, Dr. Mokdad. Since the United States federal government clearly has not enforced any federal mandates, how does this affect the model and projections or estimates in your opinion?
We do it state by state. So in our case, it's the state itself. Right now, we're moving into doing this by county, where we even look at the county. Like, for example, some states, Florida, Miami had a mandate for masks, where the state didn't. So we want to factor that in as well. But since we don't have a national mandate, that does not impact our modeling, because we're doing it at the state level and we know what the states are doing in terms of mandates. But I cannot let the question go without commenting here. And thank you for whoever asked the question. I strongly feel that the United States need a national mandate on masks, because now we're confusing the public. You know, I have a cousin in Arizona. I have first cousin in Florida. I mean, it's confusing when you and your family members or your parents live in a different place with different mandate in the same country. So having a national plan will help a lot and will send the right message, will reduce confusion. And of course, the United States needs a national plan, not a state plan, to address this pandemic.
Thank you so much. And our last speaker also said the same exact thing. Dr. Mokdad, thank you so much for your presentation today and for your important research. Would you like to provide any closing remarks before we go today?
Oh, thank you for the opportunity. Yes, I would love to tell everybody to be safe, wear a mask, stay away from each other. You know, I'm in the business of predictability. I do these models to predict what will happen. Every time I release a model, I wish and I pray that I'm wrong, and that people will prove me I am wrong by wearing a mask, staying away from each other, washing their hands, disinfecting commonly used places. This pandemic is a disaster on all of us. It will have a long-term impact. It's on all of us. We're so interconnected to work together to make sure we can control it. It's our behaviors, and we can do it if we all do our part. Thank you for listening. And if you have any questions, I put my email towards the end. I'm happy to take questions later on as well. Thank you, everybody. Be safe.
And thank you again, Dr. Mokdad, for your time and for your presentation. Before we go, I want to also thank our audience for joining us for today and for their interesting questions. And questions we didn't have time for today, and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. And this webcast can be viewed on demand for 6 months, all the way up to March 2021. Labroots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed this live event. Until next time, take care, be safe, and stay healthy. Bye-bye.
Bye.